Until the presentation is ready, I would like to thank the organizing committee, and of course, I would like to thank Al Watani Eye Hospital for giving us the chances actually to collect this work in such a high quality of recording in the operating rooms, and as I'm going to show also the supporting team from the ultrasound department who really helps in those cases of trauma. And I think it's a great day to celebrate the 20th anniversary. I wish it could have been in a different time where we can have more festivities, but still, I guess, with you present here, I guess this is a celebration in itself. Like Dr. Sharif mentioned, always expect the unexpected, and this is by chance the title of my presentation. So I'm going to just show you some of the cases. Like Dr. Sharif said at the title of the presentation, it's from PG-13 or parental guidance until R. So it's a mix. So this is the first case. It's a 10-year-old boy, blunt trauma with a football, and the left eye showed a hand motion vision with vitreous hemorrhage. Sounds like a straightforward case with no foreign body, of course. However, as we always do an ultrasound before going into these cases, you can see that the ultrasound, as I'm highlighting in the red box, has suggested a partial posterior perforation. So I referred it to my dear colleague, Dr. Rami Riyad, for repair, and Rami told me I did everything and I couldn't find any posterior perforation. So it was again, it looks like a simpler procedure to just go and remove the hemorrhage. And this is what I did. However, at the surgery, at the time of the surgery, you can see here the lower retina is almost non-existent. There is no lower retina, there is no lower choroid. This is a bare sclera. And this is, to me, it was the first time for me to see this situation, because I don't know where is the tissue? Where did it go? I couldn't find it. Of course, we remove the ILM, and I don't use a stain in most of the cases, but this also is stained with a thin film of hemorrhage. You can use a thin film of hemorrhage to stain the ILM. However, the interesting part of this case is that both the choroid and the retina are detached. So as you are doing a retinectomy or a retinotomy, you're also doing some kind of choroidectomy just to help relax this folded part of the retina and the choroid. So the whole lower half of the retina is not there, and that's why I said expect the unexpected. It looked from the ultrasound and from the exploration surgery that it should be a straightforward case. This is the choroid, and I'm trimming the choroid because that's the only way I can flatten the rest of this retina. You can see here using perfluorocarbon liquid. Still the fovea is there, so this patient had some vision after the surgery and doing the laser as usual. This is how it looked like at the end. Not bad, but of course worse than I expected from the history and the ultrasound and the exploratory surgery. This is another case of blunt trauma, a 43-year-old male with posterior perforation, repaired within 24 hours. The left eye showed dense vitreous hemorrhage with light perception vision and, of course, the rupture globe repair. You can see here on the B scan, and as I highlighted here, there is a ciliochoroidal detachment, annular ciliochoroidal detachment, which means that wherever I'm going to go into the eye, I'm going to hit the suprachoroidal space. And also, it mentions the presence of retinal incarceration and scleral fold at the site of the rupture globe. So I planned in that case not to place an infusion cannula in the pars plana. In fact, I placed it for the whole surgery in the anterior chamber, and that's another way when you see the ultrasound, it can help you plan your surgery ahead. You can see here the ciliochoroidal detachment, the annular ciliochoroidal detachment, and the case really looks bad at the beginning. You can see this ring here. It's all the retina and the choroid, suprachoroidal space are detached. There is a small break here and there, and subretinal hemorrhage. Using perfluorocarbon liquid just to dislodge the subretinal hemorrhage from the pre-existing break. And then to unveil the area of incarceration, like it was mentioned in the ultrasound report, that there is incarcerated retina temporally, and you cannot flatten this retina unless you do a proper retinectomy, and this was done in that case. Again, removing the ILM. I'm sorry, the view is always bad in those cases, but removing the ILM using a thin film of hemorrhage as the stain. And this is how it looked like at the end of the surgery. Of course, totally different than what we started with. This is a third case, a 35-year-old male patient, penetrating trauma to the left eye with repaired corneoscleral wound. And this is his ultrasound. It shows an evidence of large intraocular foreign body and the retina showing a central attachment but peripheral detachment. This posterior capsule was already opened, and this is lens matter. You can see the repair of the ruptured globe. And I did like a lensectomy or washing of the lens matter from the AC. And then I went in and I found this leathery, extremely leathery structure. I don't know what it is. And up till today, when I show this video, I'm not sure what it is. This patient had the trauma like only 15 days before the surgery. And this is very leathery blood. I thought it's part of a chalcosis syndrome because this patient had a copper foreign body inside, like I'm gonna see now. But I don't think chalcosis can happen in 15 days, and I don't think that chalcosis does this transformation of the vitreous gel into this leathery structure. But that's the case. Layers and layers and layers of a leathery tissue. And I finally could hit the foreign body. It's impacted, it's huge. I had to use several types of forceps, foreign body forceps, to just dislodge it and see then how I would get it out. It's a very irregular in shape foreign body, like you're gonna see here. And this, if you remove this from the scleral incision, you will definitely end up pulling out all the uveal tissue surrounding the scleral incision and very irregular wound. So I thought the cornea would be more forgiving, or at least the cornea is replaceable. So I filled the anterior chamber with viscoelastic and tried to put that huge foreign body in the AC and try to take it out of the... It's a very irregular shaped copper foreign body. You can see here also, this is what they call the shelving technique, and using the iris at the shelf to just protect the foreign body from falling down. But it's really a very irregular foreign body. So. And then I went back to remove more and more of this leathery structure. And again, up till now, I don't know what it was. This is the underlying retina, by the way. I'm not cutting the retina, but you can see how leathery it is. So I removed as much as I could just to flatten the retina, and I found that that's nonsense to just chase after all of this tissue. Macula is starting to be seen. And this is under air and how it looked like at the end of the surgery. This is a 28-year-old male patient, penetrating trauma to the left eye with repaired corneoscleral wound. This is rather kind of a simpler case. However, I'm bringing it to show you the again the shelving technique, and also to show you that sometimes when we have a very large retinal tear, like in this case, you will see it soon, because the foreign body was under the retina supratemporally, you have a large area of exposed choroid. So like Professor Hassan Murtada always suggested that doing cauterization of the RPE in those patients, deep, heavy cauterization, can help prevent the, this is just the shelving technique, can help prevent the occurrence of, or at least decreases the occurrence of proliferation later on after successful surgery for traumatic retinal detachment and intraocular foreign body. And this is the heavy cauterization of the area of exposed RPE, hoping to prevent the proliferation of the retinal pigment epithelial cells and other cells to the surface of the retina in the macula, and help minimize the PVR occurrence later on. This is a 35-year-old male patient, penetrating tumor to the right eye with repaired large corneal wound, and this is his ultrasound suggesting the presence of a foreign body. Foreign body was actually, at the time of the surgery, was in the anterior chamber. However, manipulation at the anterior chamber led that this foreign body fell down. So we went in again and removed it, again, same technique, the shelving technique, and removed it from the anterior chamber. I'm bringing you this case to show you that this is a large central corneal wound, and you can see already the corneal edema and how bad the view would be. But in that patient, using, this is what I just put, is glycerine. So this is a nice trick if you have a patient with a corneal edema and a central corneal wound. It's a nice trick to use glycerine. It clears the view, and you can see the view is excellent at the end of the surgery under air. This is another case. You can see here large intraocular foreign body is seen. However, it mentioned again two more small foreign bodies in this patient. This is at the time of the surgery, and I only found one, but it was a huge one. You'll see in a moment here, again, all cases of trauma usually begin by disorganized hemorrhage, and you never know, you not know what to expect under this hemorrhage. And this is what I started to see, a shiny metallic thing that it looks huge. But I didn't know its extent, its full extent, until later in the surgery. I don't know how it went into the eye, but there's no way to grasp it, and it's impacted already into the retina and the choroid. Have to do a retinectomy just to free it out. Sometimes I'm afraid to just dislodge it and then I have a posterior scleral wound or something, but in that case it didn't happen. This foreign body forceps could not actually hold it, so I had to enlarge the sclerotomy and use toothed forceps, toothed conjunctival forceps, just to try and grasp it. You can see here, this is the toothed forceps. That's the only forceps that could fit such a foreign body. And when I went out to see it from anteriorly, you can see this is just the head of the nail. So at that time, I didn't know what to do. I didn't know how to get it out. So I left it again. I enlarged the sclerotomy further. And again, with the toothed conjunctival forceps, I could grasp it and bring it out. That it's unbelievable. Really unbelievable. This is how it looked at the end of the surgery. It's not that bad. When you see this large nail and then when you see the retina at the end, it's not that bad. The macula is on. Looks okay. This is a case really interesting here about some of the fallacies that we see in the ultrasound, and nobody's immune. I mean, ultrasound, as I tell the patient, you're holding a candle and you are suggesting that there is a door here, there is a window there. So in that case, I had no evidence, ultrasonographic evidence like you can see here, of a foreign body. However, there was a clear self-sealed penetrating wound in the cornea, and of course in the iris and the lens. So there must be something that went in. Of course, it could have went in and then went out, but usually it would not look that rounded. And I was right, there is a foreign body right there. It's small. And also bringing this case to show you that sometimes you don't need to remove the whole vitreous before getting the foreign body out. Just that free the track that you're gonna pull the foreign body through, because sometimes you can use the posterior hyaloids as a cushion to protect the underlying retina. Of course, examining the periphery is very important. This is the last case, and this is a very interesting case as well, because here the ultrasound suggested the presence of foreign body. However, when I went into this patient, everything was perfect. Wow, the retina is perfect, just some peripheral detachments, lower nasal, but the macula looks perfect, looks great. And then I said, ultrasound said there is a foreign body, there must be a foreign body. So I started searching at the very far periphery, and yes, I found an impacted foreign body under the retina. I'm freeing it from under the retina at the very far nasal periphery. And actually, the ultrasound was very correct about prescribing it in the nasal periphery, but I didn't know it was that peripheral. So I'm working here with the microscope without the wide viewing angles, wide viewing system, and trying to dislodge such a foreign body that could have been missed if it wasn't for the ultrasound. And probably this patient would have come later with siderosis. It was a relatively small foreign body, and it was a little bit tough to free it from the peripheral retina, but at the end of the day we got it out. And that's it. Thank you very much.